So I'm just going to start. I generally start my presentations with giving people a reminder of what the situation for people age 65 and over is in the province of British Columbia. So as many of you will know these numbers. They don't shift dramatically year over year, but let's just take a look-see at what's happening across the province. So this year, we crossed the magical threshold, and there are now over 1 million people age 65 and over living in BC. 20% of our population. And I think the important thing to remind ourselves of is that that means 8 out of 10 people in British Columbia are under the age of 65. So before we get carried away thinking that it's all about seniors and seniors are voting everybody into office and directing everything, I think we need to take a step back and realize actually that's not the case. The majority of people, the vast majority of people, are still under the age of 65, and they are still the major drivers and influencers of policy and resource allocation in the province and the country at large, and will be actually for the foreseeable future. So we need to keep reminding ourselves that seniors do need the additional protection or advocacy, if you will, of a minority population, because they are. So 93%, over 9 out of 10 of people over the age of 65 in BC live completely independently. And that's important to remember as well, because when we look at people over 65, everybody doesn't look the same, act the same, and live the same way. There is great, great diversity amongst the million people that we call seniors in this province. And I look at the age 85 for a lot of data, and it will become more evident in the next slide. But one of the reasons I look at 85, it is when we start to see a marked difference in the use of the healthcare system. And it's also pretty close to the average age of somebody living in a nursing home in British Columbia. So when we look at 85 plus in BC, over 7 out of 10 people live independently. 72% of people 85 and over in this province still live independently. About 10% live in what we would call a retirement community or assisted living. Those lines can get blurred a bit, but in practical terms, it means they're living in a congregate setting. They have their own unit or apartment. It will often have a kitchenette or a kitchen, usually a separate bedroom, and they have common dining where they may get together for dinner or maybe all 3 meals a day and have some common activities if they wish to participate. Some people who live in these sites will receive some assistance and care. Some will receive none. They're simply there for companionship and not having to cook anymore. So that's about 10% of our population, 85 plus. 15% of people 85 plus live in what we call long-term care or nursing home or residential care. They're all captured in the same spirit of 24-hour on-site response and care provided for the people who live there. So what that means is that 85% of the people over the age of 85 in this province do not live in long-term care. And so we need to remember that, particularly now when there's a significant focus on long-term care, and there should be, and there are going to be pushes for improvements and changes in long-term care, and there need to be, but we need to remember that looking at long-term care and fixing long-term care does not in and of itself address the needs for the majority of seniors in British Columbia or indeed in Canada. So let's look at the income of seniors, and this is where there's a little bit of a oh, really moment from a lot of people. The median income, and most of you will know that means 50% are above and 50% are below. The median income of somebody 65 years of age and older in this province is just over $29,000 a year. That's just a little bit above a minimum wage job, full-time minimum wage job. And almost a third of BC seniors are on the Guaranteed Income Supplement, the GIS. And this is really, so the 28%, the almost a third that are on the Guaranteed Income Supplement, The reason why this is a good proxy for poverty is because GIS does factor in household income. So this is not a situation where a particular individual has a low income, but their spouse has a high income. That's not what you're seeing with people on GIS. And this group of people have an income generally less than $25,000 a year, and that is less than a full-time minimum wage job. So that's almost a third of our seniors. 27% have personal incomes under 20,000. Now, this number is skewed ever so slightly by people who might in a particular year have a significantly lower income than another year. But when you put the two together, you get a pretty good idea that there's, roughly a third of our seniors who really do have some challenges around sufficiency of income. Just over 30% of people 65 to 69 are employed. This number has grown since I started doing these presentations. It was 24% when I started, and I predict it will continue to grow. We are not just living longer, we are living healthier, and the generations that are coming up have started their permanent full-time engagement with the labor force, as we call it, at a much later age than preceding generations. So time taken out of the labor force for post-secondary education, for exploring what life's all about over in Europe for a couple of years, all of those things are adding up to make it less likely that we've got our full 44 years into the CPP plan at the age of 65 than it was for preceding generations. So I think this is healthy, and I think that we will continue to see that number grow. 40% of people 65 and older volunteer. Very strong contributors to our communities in a whole variety of ways. At the age of 65, 91%, over 9 out of 10 people have a driver's license. By 85, that's down to 36%, less than 4 out of 10. And yet, people are still living independently. They are volunteering. They're wanting to get out and about. They don't have unlimited incomes, but they no longer have their private vehicle. And so that is something I think we need to look at in terms of what changes we're going to make in the future. Also, the probability of living alone increases significantly as we get older. And this is particularly, I think, something we want to look at in the context of the past year with COVID and with requirements to isolate, and in the beginning of the pandemic, our stay-at-home orders. If you look here, you will see this group here. This is the group 65 under the age of 65. You see a big group here, the 35 to 55-year-olds, over 90, well over 90% are living with somebody else, a spouse, their adult children, a combination of both. Even the 55 to 64-year-olds, you still have well over 85% are living with somebody else. Then you start to see the probability of living alone increasing each and every year by these 5-year age cohorts. And the most dramatic jump is actually in the first jump from 65 to, from 65 to 70 in terms of living alone. So think about the impact of that in the past year, when in addition to when we look over here at the 85 plus, much more likely to live alone, much less likely to be able to drive, to get to places, to be with other people, and not having a lot of financial resources. So the impact has been more profound, I think, on community dwelling volunteers, community dwelling seniors than we might have otherwise recognized when we start to look at all those factors. I'm just going to spend just a quick time on this. What these data are telling us is the dramatic increase in the proportion of the population 65 plus relative to the proportion of the population under 65. And this is just a reminder that we have not yet seen the full impact of the what we call the boomer generation. The beginning of the boomer generation will be turning 75 this year. So the stresses that we are feeling on the system now have are 10 years away from really feeling the impact that we'll feel when the boomer generation starts to come through. And you see that when you look at our segmented population and some of the health conditions. So one of the classics is when we look at dementia. So obviously, if you're under 65, the prevalence of dementia is so small, it doesn't even register to 1 decimal point. It's possible, but it's not probable when you're under 65. When you look at the entire population, 65 plus, it's 6% of the population 65 plus is diagnosed with dementia. But look what happens when you break that down between the 65 to 84-year-olds and the 85 plus. In fact, only 3% of the population 65 to 85 is diagnosed with dementia. It's when you get 85 plus, it's 20%. And remember, the boomer generation is 10 years away from being 85. Now, I think it's also important to recognize that it's only 20%. So 8 out of 10 people over the age of 85 do not have a diagnosis of dementia. And that's important when we think about our planning and when we think about where we want to live as individuals and where we want to plan for people to live as they age. And then as you can see in these data as well, it just reinforces when you look at the 65 to 85 group and the 85 plus, most of these numbers change by a quantum of double when you get to 85. And what that shift is telling us is that it's really at age 85 plus when you start to see these very marked differences in terms of utilization of the care system and in terms of care needs. So what are the challenges that have been identified during the pandemic? Well, certainly there have been a number of challenges that have been identified to the public at large. I would say that for those of us who've worked in the field, they weren't revealed by COVID. We knew they were there, but I think they've been certainly amplified by COVID, and then they have been revealed to the public at large. So we know within our care home staffing, both the sufficiency of the staffing and also what I would call the precariousness of the staffing. So having physically enough boots on the ground, as we say, is only part of the issue of appropriate staffing and long-term care. Making sure the staff are consistent, which is what's necessary for not just building relationships with residents, but also familiarity with facilities and familiarity with infection prevention and control practices in each facility are also key to providing good and safe care. And we certainly found challenges around both of those in terms of the staffing during this pandemic. The marginalization of familial relationships, without a doubt, we have when we are through this, on the other side of it, all of us in healthcare are going to have to do some agonizing reflection on the value or lack of value we put on the familial relationship, particularly as it comes to the quality of life and the health and well-being of people who live in residential care. To say that we recognize how important families are is inconsistent with how we have treated families of people living in residential care for this past year. And I think many of us will have the generosity of heart to recognize that we were seized by a pandemic. We were in uncharted territory. We were responding to changing dynamics almost daily. And many things we predicted or thought might have happened didn't exactly unfold the way we thought or predicted they might happen. And all of that, I think, can be used as a rationalization for why we had to do, or not had to, but why we did what we did the way we did. But we have to have the capacity and the humility to reflect on the fact that our actions did not support a philosophy of the importance of familial relationships. And that's in residential care and acute care. And it is about the healthcare system writ large. We also saw identified in care homes the issues of public care homes versus contracted care homes. You know, what rights does the public have to dictate to private operators what they can and can't do when they've got publicly funded residents? I think there's going to be a lot of discussion about that. I think the value of the quality of life versus sustaining life has to be examined in the context of long-term care. So yes, we kept people safe, but for what purpose? So if we look at the deaths in long-term care versus the deaths from all the other things in long-term care, many of which are preventable, I think again, in my, going on 25 years now in seniors care, I've never seen immortality as a goal of care on any care plan I've ever seen. So we've got to really understand what that means, and that segues into rights versus risk. It's challenging in a congregate setting around an individual's right to put themselves at risk and how that might put others at risk, and where is that line? But certainly a number of issues in care homes were identified during the pandemic. There were also a number of issues identified in the community. So the issue of living alone, which in and of itself is not necessarily an indication of loneliness. A person can live alone and not be lonely. A person can live with a number of people and feel lonely. But living alone is a risk factor for a number of things, and that was amplified during the pandemic as suddenly there was nowhere for seniors to go, certainly for the first 4 months of the pandemic, where they could socialize with other people. Our recreation centers were closed, our libraries were closed, our senior centers were closed, our municipal town halls were closed, everything was closed. Costco apparently wasn't closed, you could still go there, but we were certainly giving a message out, and I was part of that message while we were trying to figure out what was going on, of encouraging older people to stay at home. And the living alone made that those stay-at-home orders, for want of a better term, look different. Certainly for the older adults, people over 80. Not driving. Well, now we're in a situation where sharing a taxi cab, getting on a bus, having a volunteer drive you, having another family member drive you, having another person in the car became a risk factor. Didn't have an impact on me. I can drive alone in my vehicle. But if I couldn't drive, it has put an additional strain on me that would not normally be there but for COVID, because I could get a volunteer to drive me. I wouldn't hesitate to have another person in the car. Low tech. We talk a lot about the fastest growing group of Facebook users is people over 65, and you hear all these. But the reality is, when you actually look statistically at the numbers, the participation rate in technology is much lower in the people over 65 than under, and it is lower still in people over 80 than people 65 to 80. And so that became a real issue as we depended more and more and more on technology during the pandemic. And low income. Low income became more of an issue. Now, seniors were not impacted on their income by COVID to the extent that younger people who may have lost their job were, but the expenses they incurred increased as a result of COVID. So whether it was having to pay for grocery delivery, having to pay for a taxi cab versus a friend who would normally drive them but didn't during the COVID restrictions, certainly this became an issue. And it also ties into low tech, because the number of seniors, while they can navigate the email and some of the internet, they can't afford the Wi-Fi, and they would go normally to their library or their senior center to use the Wi-Fi. Those places were closed during COVID, and so they were cut off even more. And it highlighted the importance of the libraries, the senior centers, and the rec centers. And these were all some of the latest places to reopen and have not completely. Libraries didn't. I can't figure out why we took so long to open our public libraries, but we did. They were not open until the fall. And so that was a fairly long period of time that seniors went without the support from the library, which we may have underestimated. The other challenge during the pandemic was finding bandwidth to deal with anything that wasn't COVID related. So we've got an abuse and neglect report we want to get out. We've got an incomes report related to costs of healthcare we want to get out. We've got a variety of things. And the reality is nobody has any bandwidth right now to listen to anything that isn't about COVID. We thought we were maybe gaining some bandwidth, and then the third wave came along. And when it comes to seniors, the focus is all on long-term care at the moment. And we need to be very, very careful of that, because while long-term care does need more attention, without a doubt, it is not what where the vast majority of seniors live or ever will live. And we need to remember that. We need to remember that community supports are necessary as well. So let's talk a little bit about COVID in long-term care in BC. We have this data, these data are correct, I believe, as of the end of March. And as you know, there has not been dramatic activity related to COVID in long-term care, thankfully, over the last few weeks. So in British Columbia, there are 521 long-term care and assisted living sites that were covered by the public health order because they are either under the Community Care Assisted Living Act or the Hospital Act. So these numbers do not include what we would call independent living sites, which were never captured by any particular public health order. There's no regulation. There's no way to accurately know how many are out there. So there's 309 of these sites are long-term care, and 212 of them are assisted living sites. Most of the long-term care sites are a combination of either exclusively publicly funded beds or some privately funded and mostly publicly funded beds. And there's a handful of sites that are exclusively private pay long-term care beds. Most of the assisted living sites are a combination of private pay and publicly funded. There are very few completely publicly funded assisted living sites in the province. Almost all of them are run by contracted providers versus long-term care, where a third of them are operated by health authorities. So that's a bit of context. 309 sites had no outbreaks. So just the majority of sites did not experience an outbreak during COVID. Of the 212 sites that experienced one or more outbreaks, they experienced a total of 358 outbreaks. So, and I don't need to tell Providence, as you know, some sites experienced multiple outbreaks. Overall, 51% of our long-term care sites experienced an outbreak. 77% of long-term care sites in the Lower Mainland experienced an outbreak. So there's a clear linear relationship, as we would call it, between the level of COVID transmission in a community and outbreaks. You can see that when you look at the map. But even that didn't look the same between long-term care and AL. Only 17% of assisted living sites experienced an outbreak, although again, the bulk was in the Lower Mainland. 56%, over half, just over half of the outbreaks were contained to one staff person. They did not infect a single resident. 69% of the outbreaks involved less than 4 people. And 75%, 3/4 of our outbreaks, resulted in no deaths in long-term care. So this is where our review really has the most questions to ask. Whether or not you experienced an outbreak, we predict is going to, for the most part, be linked to the likelihood increased if your community spread was higher. We know that from initial numbers already. We may find some other difference, but we're not expecting to. The real question we want to understand the answer to is, why did some facilities experience prolific outbreaks, large outbreaks, while others experienced very contained outbreaks, given that these outbreaks would happen relatively at the same time in the same community? So the community spread, and other factors were the same. What were the differences that led to an out-of-control outbreak and a contained outbreak? And we're just in the beginning stages of analyzing why that might be, and we're hoping to be able to provide some answers to those questions at the beginning of the summer. There were a total of 4,200 cases in the 358 outbreaks, 2,615 residents and 1,667 staff cases. There were a total of 778 deaths, which is 53% of all the COVID deaths in the province. So you will notice that this is lower than other numbers that we've heard. I would caution, British Columbia's second wave looked very different from our first wave. Ontario and Quebec had extremely horrific first waves. We did not. Their second wave, in the case of Quebec, was actually better than ours, and in the case of Ontario was about the same as ours. But the impact of that first wave, particularly around long-term care and long-term care infections and long-term care deaths, drove data because of the numbers in terms of a large Canadian average. So, and I also know that this number will go up a little bit when we start to sort out those residents who were transferred to hospital and died in hospital would have their location of death recorded as hospital initially, and it's going to take there's a lag until we can tag that back to long-term care. But what this picture tells us is we've had, I think something in the neighborhood now of 110, 120,000 cases of COVID in the province, 4,200 in long-term care, or 2,600 residents in long-term care. And that is less than 10% of our residents in long-term care contracted COVID. And 778 people in long-term care died from COVID. By the time we're through this, that number, for sake of argument, is 800. Remember that in a given year, about 8,000 people die in long-term care of things obviously other than COVID. We're looking at whether, in fact, there is excess death in long-term care. There was an article in the Globe which came up with a different number than we did. We're not seeing what we would call a statistically significant difference in deaths in long-term care over the period of the pandemic, in part because some of the measures we took to keep COVID out may have reduced deaths from influenza. There may have simply been a substitution effect. But remember that while these 800 people have died from COVID tragically, think about the approximately 8,000 people that died of something other than COVID and how they spent the last year of their life in long-term care. Because the couple of things I want to talk about now. So as many of you may know, we did a very extensive survey in September of family members of residents in long-term care about the impact of the visit restrictions. When people were answering this question, they had been allowed to visit under the revised one designated social visitor policy for 2 months by the time they answered this. And their loved ones had been under visit restrictions at this point in time for 5 months. 5 to 6 months by the time they answered this. Now, there was another 7 months after they answered this survey of people still living under the kinds of restrictions that were in place when people answered this survey. So when we look at it, we asked people, what was your frequency of visiting before, and what is your frequency of visiting now? So before the pandemic, you can see that the majority of people, 59%, visited several times a week or daily, right? So this is a very involved family member whose relationship with the person in long-term care is very strong and undoubtedly links to that resident's quality of life and to the level of care they are receiving. For a year, the majority of people were visiting only once a week or less. Gone were the several times a week or daily visits. Then we asked people about the duration of their visit. So before the pandemic, what we see here is that the vast majority of people are visiting for more than an hour, and that about just over around a third would be visiting for an hour or less. What they've experienced for the last year, half of them were getting 30 minutes once a week. Some were getting an hour once a week, an hour or up to an hour, right? So think about that shift for that resident. Think about the spouse that used to come and visit daily, now can only come once a week for 30 minutes in a common area, wearing a mask, 6 feet apart. That's what they got for, in fact, they didn't even get that for a year. For 3 to 4 months, they got nobody. And then for the following 8 or 9 months, they got once a week for 30 minutes in a common area, 6 feet apart with the mask on. Some even had plexiglass. So clearly this had an effect, and we see this. This is the prescribing for antipsychotics in long-term care. This here is when the pandemic started, okay? This here is the preceding 3 years. So you can see we bounce around a little bit, right? And these are 3-month increments, right? Or 2-month increments, I think. Yeah, 2-month increments. So we bounce around a little bit. You can see that, right? And then look, pandemic hits, up, 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 up. Oh, we thought we were getting better, up, up. And this, when we took this measure, this graph demonstrates, I think, an 8% increase. It's now a 10% increase. It's continued to go up. In my time of measuring these data, I have never seen a decrease of 10% in a single year, or more precisely 10-month period, either up or down. We have wiped out all the gains of our campaign to reduce antipsychotic use in long-term care, which, by the way, was successful. And we are going to be monitoring this and hoping that if it went up this dramatically, it could go down this dramatically. So we're hoping to see that when life returns more to normal in long-term care. It's not back to normal yet. Part of this will be a reflection of the visit restrictions, but not all of it will be a reflection of the visit restrictions. Some of this will be a reflection of people forced to isolate for 14 days when they were first admitted. Some of this will be a reflection of the strains on the staffing, which have made less time available for some of the non-pharmacological interventions to de-escalate agitation and aggressive behaviors. There'll be a variety of reasons. It won't just be the visit restrictions. So it's not going to look the way we want to see it look for probably possibly another year, but then we should be starting to see that downward trajectory. So this is a real impact that our residents have experienced. So post-pandemic changes, we need to assess what we learned. We need to put our experience into perspective, and we need time in order to do that. I don't think we're at a place yet where we can put this whole experience into perspective. We need to remember that most seniors want to and do live at home in the community. We need to understand the impact a person's income has on the choices that are available to them. The income in and of itself no longer buys better health by the time you're 85, but it does buy you different choices if your health starts to decline. We need to focus on the quality of life balanced against risk, and we need to recognize that immortality is not a goal of care. And without a doubt, we need to re-examine the attitudes of healthcare towards family members of patients and residents.